there is a lot of controversy about local treatments. And the first thing I can tell you is there is no large randomized clinical trial of surgery versus radiation. Okay? There have been little bits and pieces. Paulson did one years ago. Southwest Oncology Group, we tried to do it with Peter Scardino when he was in the group. But there's a lot of studies like radiation plus or minus 4 months of hormones, 6 months of hormones, radiation this, radiation that. So what we have to do, and again, this is sort of the art of medicine too, the treatment of prostate cancer, the patients are influenced by us. You know, I pretty much can talk a person into what I want to most of the time, and most of us are good salesmen, can do that. Is that the right thing? No. I mean, so if you have, and you see it, there's plenty of data to support this. If you just bought a proton machine, guess what patients are going to get? If you just got an IMRT machine, guess what patients are going to get? If your hospital just got a robot, guess what patients are going to get? And so we influence a lot of what happens, whether right or wrong. And the family, you know, the friends, oh, yeah, this guy had a radical prostatectomy, and he's the most miserable person in the world because he leaks all the time, or he's had strictures, or his PSA went up. And, you know, these sorts of things, you see this in support groups and things like that. It's hard to control for a lot of that stuff. The media. Mike Cookson just showed you the book about the prostate snatchers, and everything else is out there that influences our decisions. And newspapers, support groups. I think support groups are great, but I also think they're horrible in a way because some of the information out there is not balanced. I mean, you got a couple guys that are sort of the same ones that are either really happy with their treatment or extremely disappointed with their treatment. And you can see them sort of control the whole group in a way. And so a lot of this stuff is, you know, I offer support groups, but there needs to be some medical oversight and balance in there to sort of talk about it, because it's amazing what you see. And then the side effects. I mean, there are people that, you know, say, there's no way that, you know, I just got married and I'm 48, and I don't want to have erectile dysfunction, okay? So, you know, I'm going to go with observation or radiation, things like that. And we see this all the time. I remember being on Good Morning America with Norman Schwarzkopf years ago when he was talking about his cancer, and he said, as far as I know, the most common cause of erectile dysfunction is death. So, you know, you say that to people too. But, so, you know, anyway, I was going to say marriage, but I shouldn't say that. Can you X that out of that thing? What I just said? Okay, because I'll be in big trouble. Okay. Intent of curative therapy. Intent of therapy, is it curative? Is it preventative? Delay progression? Palliative? We have patients that have metastatic disease. We're talking about treating the primary right now. So there's many things that go into it. And so, you know, if you're a urologist, this is what you tell patients about radiation, okay, is that you're going to get treated, you're going to have rectal problems, bladder problems, things like that. And that is, as you well know, not the case today. And then this was given to me by a radiation therapist, Bob Kagan from Kaiser in Los Angeles. Sort of that men that have a radical prostatectomy have a faucet, they're leaking all the time, drip, 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 drip. And so, you know, we do bias this. So, yeah, I could spend an hour or 2 hours, and I have, giving talks about, you know, benefits of surgery, radiation, neoadjuvant, things like that. We don't have time for that. And I think that it's not one-stop treatment. And that's one of the good things about multidisciplinary approaches, is that you can talk about the different treatments, radiation, surgery, have the patient see the radiation oncologist. There's a role for cryotherapy. There's also a lot of other things. We're going to talk about some of those tomorrow or this afternoon, some HIFU and cryo and things like that. But, you know, there are some advantages of everything. Advantages of prostatectomy, it's sort of the gold standard. Staging is what knowledge is power. You know what's in the prostate. Local control. Radical prostatectomy doesn't care if you're Gleason 8 or a 6. Whereas other treatments they're not so sensitive when they're higher grade cancers that you have to combine things and complications and survival. Dr. Whitmore, who trained Dr. Donahue right here years ago, said this famous saying, "Is treatment sufficient for those in whom it is necessary and necessary for those in whom it is sufficient?" Is that right? Is that the way he said it, Bob? Close to it. You always tell me it's wrong. But anyway, inside, we treat a lot of people that don't need it, and the ones that we do treat, we can't help them anyway. But let us say that Dr. Whitmore did die of prostate cancer. So Dr. von Eschenbach, who was the director of the NCI not too long ago, a urologist from Houston, said that the transition in oncology, and I think this is perfect today, is the 20th century was seek and destroy, the 21st century is target and control. And that's cutting down on the symptomatology. Dr. Terlecki mentioned some infections and bacteria in prostate cancer and inflammation and all this other stuff. I mean, we might laugh at that. When I was a resident, one of the more common, on general surgery, one of the more common operations we did were antrectomies and pyloroplasties, vagotomies, things like that. When's the last time anybody did one of those? Anybody remember doing one? We did a lot of them. You know what happened to that? One pill put that out of business, right? It's called Tagamet, okay? One pill is going to put prostate cancer out of business, believe me. If not, it's going to be an immunological thing. I talk to our residents now about we're doing all these robots and this and that. And I don't think you're going to be doing those in a few years. We got ways around that. So we need to stay on top of the whole disease, embrace it, and so forth. And, so this is one of the things. And now the male lumpectomy. And what is that? That's just treating the whole, not the whole prostate, but just the cancer. How many times have you had patients say to you, "Doc, why do you have to take my whole prostate out? Why can't you just treat the cancer?" And we go, because it's multifocal and, it's going to, whatever's causing it's going to come back here and there. We say that. But really? Now we have ways to do that. We've been doing this for over a decade, and now it's one of the hottest things you see in all the journals, the focal therapy and things like that. What we've did, and we've done almost 1,000 now, are transperineal mapping biopsies. What those are is that you go through the prostate with a template and 5 millimeter intervals, and we'll do up to 100 biopsies. Our record's 180. And then we 3D reconstruct that prostate and put it together. So it's a very laborious, intensive labor procedure. This is the ultrasound, the biopsies, we go through there, we label every one of these, goes in a separate thing, and so forth. And then we have our computer here, and then this is what we get back. We get these 3D images, and here's the cancers, the 7s and 6s, and so forth. This is one we just did in June. And you can look at it in 3D and say, okay, here's all our needles and everything. We can maybe we'll put a cryoprobe right here and one right here. That's it. Or, a lot of these are anterior tumors, and just treat them. And that makes sense. It's the male lumpectomy. It resonates. So a lot of the stuff we're doing is going to be different. So let me ask this question again as I finish up here. What % of men have a PSA of less than 1.5 in the screening population, less than 50, less than 30, greater than 70, greater than 80? All right. God. Ryan, I've learned from you how to get there. This is a urine test. This is a urine-based test to detect aggressive cases of prostate cancer. PCA3, 4K, select MDX, or phi. So not quite perfect. PCA3 is a good test, and I'll talk about this probably more tomorrow morning. The problem with PCA3, it doesn't differentiate high-grade cancers. So PCA3 is dead. And it's being replaced by 4K select. Actually, phi is a pretty good test too, and I'll tell you some more about that tomorrow.